Now, yesterday we stopped at airway obstruction, and prior to this particular slide, we had looked at the common things that can obstruct the airway. Now, when a patient has a obstructed airway, it can either be completely obstructed or it can be partially obstructed. So you definitely want to determine if the patient has an obstructed airway. And if a patient is choking and that particular patient is able to speak or is able to cough, then the airway is not completely obstructed. And once the patient has a strong cough or is able to cough, you want to encourage that. So if it's partially obstructed and there is good air exchange, all you have to do is monitor the patient's airway. If it is severely obstructed, so if the patient is not able to speak or has a weak cough or no cough, then you would treat that like a complete obstruction and you would follow your BLS guidelines or CPR guidelines. Mild airway obstruction, the patient coughs and gags, the patient may be able to speak, but with difficulty. Again, if the airway is partially obstructed and they have good air exchange, just monitor. They can cough, encourage them to cough. If it's partially obstructed with poor air exchange, then you treat that as a complete obstruction based on your BLS guidelines. And there is a video recording for BLS review if you have not done BLS as yet in your recorded lectures. Now, still on mild airway obstruction, encourage the patient to cough. If the patient cannot expel the object, arrange for prompt transport. Now, with severe airway obstruction, the patient is unable to breathe in or out, and speech is impossible. Other symptoms may include poor air exchange, increased breathing difficulty, a silent cough, loss of consciousness in 3 to 4 minutes. Treatment involves abdominal thrust, and this is going to be based on your BLS guidelines or protocols. Now, specifically, and this is just a review, management of mild airway obstruction simply means that there is an obstruction, but the patient has good air exchange. That occurs, encourage a patient to cough, monitor the patient airway, transport the patient, or arrange transport for that patient. Severe, the patient will have poor air exchange. This is something that you physically need to do something about, and you'll follow your BLS guidelines for that. Now, if the patient is conscious, stand behind him or her and perform abdominal thrusts. And this is just a review of the BLS guidelines. To assess a patient with a complete airway obstruction, there are steps that you would follow based on your guidelines. And really, the only significant changes if the patient goes unresponsive and you suspect airway obstruction, before you do any ventilations for this patient, you will assess the airway to see if you can see the object. And if you can physically reach it, you remove the object from the patient's ear passage. For airway obstruction in a child, specifically infant or small child, tilt the head back just past the neutral position. If the child becomes unresponsive, perform CPR 5 cycles before activating EMS system. Airway obstruction in infant, if the infant has an audible cry, the airway is not completely obstructed. Use a combination of back slaps and chest thrusts. If the infant becomes unresponsive, then you will perform CPR with. The only variation is going to be when you attempt to ventilate. Prior to ventilating the patient, you will check the ear passage to see if you can see the object. If you see the object and you can physically remove it, remove it. All right, now oxygen equipment. As an EMR, you may have to interact with the oxygen cylinder. Now, oxygen cylinders, oxygen is compressed to 2000 psi and stored in portable cylinders. The portable oxygen cylinders used by most EMS systems are either D or E size. So the cylinders that are used on the ambulance is either a small cylinder and a large cylinder. And you have 2 sizes for the small cylinders. You have one that can hold on the stretcher. So it's about the width of the stretcher. So that's probably one of the smallest that you can use for the patient. Now, oxygen is a medication, and that needs to be clearly understood. So if you are going to be administering oxygen to any patient as an EMR, there must be an indication. Again, we cannot treat what we have not properly assessed. So there must be an indication for you to administer oxygen. Now, depending on the flow rate, each cylinder should last for at least 20 minutes. And if you are doing CPR on a patient, a cylinder can finish fairly quickly if you're running a code. Now, the cylinder, when filled with oxygen, it is 2000 psi. We cannot give a patient 2000 psi of oxygen. Their lungs would not be able to withstand that. So there is a pressure regulator, which the purpose of the pressure regulator is to reduce the pressure within the oxygen cylinder to a much lower pressure, 50 to 70 psi. And then we're able to titrate the flow meter based on whether we need to give the patient low flow oxygen or high flow oxygen. And if you're going to be administering oxygen, always start on the lower end of the device that you're using and gradually go up if the need arises. So the flow rate can be adjusted to from as low as 2 to 15 liters per minute. Now, anything below 10 liters per minute is considered low flow oxygen administration in EMS. So anything below 10 liters per minute is considered low flow. Well, let me rephrase that. Anything below 8 liters per minute, because a partial rebreather can give 8 to 10 liters per minute. So anything below 8 liters per minute is considered low flow. Anything above 8 liters per minute would be considered high flow. Now, keep in mind that there are certain patients in which high flow oxygen administration can cause more harm than good. So again, if it is not indicated, it cannot be administered. So once the cells in the body are properly oxygenated, the red blood cells specifically, it can only hold 4 oxygen molecules. So if there is excess oxygen molecules present in the body, it can damage the red blood cells that already have oxygen molecules attached, and that can interfere with oxygenation of the cells. Also, if there's too much oxygen in the body, because the capillaries can only facilitate 1 oxygen molecule at a time, sorry, 1 red blood cell with oxygen on it at a time, then if there's excess, the body will vasoconstrict, and that term vasoconstrict means it's going to narrow arteries that supply the heart and the brain to protect them. So the arteries that feed the brain and the heart will get small, or the diameter will constrict, or the diameter, the size of the vessel will be reduced to protect the organ. And if you have a patient that is having a heart attack, that can cause serious complications. So if their blood vessels, the coronary artery, which is very tiny, start to vasoconstrict, that can make the heart attack worse. And that's if you give a patient with a heart attack too much oxygen, or oxygen when it's not required. The same thing can occur if a patient is having a stroke. So if a patient is having a stroke, the blood vessels that supply the brain is not very large. So if you give that patient too much oxygen, the blood vessels will get small or reduce in their diameter when the brain needs blood. That's not good. So again, if the oxygen is not required, then it should not be given. And it's going to be based on your assessment. So when you need to determine if you're going to give a patient oxygen, you're going to look at how that patient is communicating with you, right? So is the patient able to have I don't want to use the term sensible conversation, but is the patient oriented, fully oriented, can tell you their name, can tell you what's happening, stuff like that. You're going to be looking at that. If they're fully oriented to your presence and your questions, then you need to look at the patient's breathing. Is it fast? Is it slow? Is it irregular? Is there muscle use? Can you hear abnormal sounds? Is it positional? Can you see visible chest rise? And once a patient is breathing too fast or too slow, or the pattern is irregular, or you can see muscle use and the chest rise is affected, then this patient would benefit from oxygen administration for sure. And definitely, if the patient's level of consciousness is compromised, the patient will require oxygenation. So if a patient is confused or disoriented, there is something wrong with perfusion to the brain. And for the brain to be properly perfused, it needs adequate water, salt, sugar, and oxygen. That's what the body runs upon, you know. Water, salt, sugar, and oxygen. If that is compromised, a patient will not be able to communicate with you properly. So remember your parameters, and this is an additional skill. It's not a required skill for EMTs, but as I say, you need to be familiar with the oxygen equipment. That if you're working with an EMT and they say, get the oxygen cylinder, you know what they're talking about. If they say, get the nasal cannula, or a high flow mask or a low flow device, you should know what you're talking about. Now, nasal cannulas and face masks. A nasal cannula is a low flow device. A face mask is considered a high flow device. So ensure the oxygen is delivered to the patient and it is not lost in the ear. The nasal cannulas are used to deliver medium concentration of oxygen, and nasal cannulas are used only for low flow. So we don't use nasal cannulas for medium or high unless it's a paramedic. So a paramedic can go above the standard level of a nasal cannula. As an EMR, if you're using a nasal cannula, you will not exceed 3 or 4 liters per minute. A face mask is placed over the patient's nose and mouth to deliver oxygen. So it's going to be either a nasal cannula, a face mask, or non-rebreathing masks. And in EMS, the two most commonly used oxygen devices is going to be nasal cannulas and non-rebreathing mask. And a non-rebreathing mask is a high flow device. And this is a mask in which the outside ear does not mix with the oxygen. The patient is getting pure oxygen when they breathe in. Now, safety considerations. Oxygen actively supports combustion and can quickly turn a small spark or flame into a serious fire. All sparks, heat, flames, and oily substances must be kept away from the oxygen cylinder. And if you're functioning in the field with an oxygen cylinder, a humidifier should not be on it at that point. So if you're going to be using a humidifier, wait until the patient is in the back of a unit. And that's if you're required to assist the responders in the back of the unit. But the humidifier, put it on in the back of the ambulance, not in the field. Once the humidifier is on the oxygen cylinder, which is basically a container with sterile water, and the purpose of a humidifier is to moisten the oxygen so that it's easily absorbed into the mucous membranes within the ear passage. Moist oxygen is going to be beneficial for patients who have infection. So any patient that has an infection with breathing problem will benefit from humidified oxygen, because infections cause the body to dehydrate. So their mucous membranes are going to be dry. And when the mucous membranes are dry, it's difficult for them to absorb oxygen. So humidified oxygen would benefit these patients. And to be even more specific, any patient that has an upper or lower respiratory tract infection. And the most common example right now, for instance, a COVID patient, a patient with flu who has a lung infection. These patients will benefit from humidified oxygen. A patient who has an upper airway infection, lower airway infection, a patient with airway burns, these patients benefit from moist or humidified oxygen. But we do not carry the humidifier on the oxygen cylinder, excuse me, in the field. Because if a humidifier is on the oxygen cylinder in the field, the cylinder has to remain upright. And that can be difficult to navigate in the field. Once the cylinder starts to tilt, fluid from the humidifier can get into the tubing for the oxygen device, and that can end up in the patient's face or nose. We don't want that. The pressure in an oxygen cylinder can cause an explosion if it is damaged. It's compressed. Oxygen cylinders should be kept inside sturdy carrying cases. Now, administering oxygen, not going to focus too much on this particular skill. I will certainly demonstrate how it is done face to face, but not something that I'm expecting you to learn at this point. Definitely need to be familiar with it though. So place, not going to go through the steps. It's going to be easier for you to understand when you watch the videos and come face to face. But in a nutshell, if it's a new cylinder, the cylinder is going to have a seal. You need to ensure that it is a oxygen cylinder. So once you have removed the seal, the cylinder needs to be cracked to get dust out of the port. And then you put on your regulator, which has a pin indexing system. So there are 2 pins on the regulator that will fit in 2 holes on the cylinder stem. And it is designed that way so that that regulator can only be attached to an oxygen cylinder. Once the regulator is on the cylinder and it fits properly and it is tightened, then we turn on the cylinder and check that cylinder for leaks. No leaks, then you can attach your device, appropriate device, whether it's low flow via nasal cannula or high flow via non-rebreathing mask or partial rebreather mask. And then you set it at the desired flow rate. Regardless of the device that you're using, you will start at the lower end for that particular device and gradually go up as needed. Now, all right. Now, important point to note, once you have initiated oxygen administration, if you're going to switch between devices or discontinue, never turn off your oxygen flow with the device on the patient, especially for your face mask or your non-rebreather. Remove the device, then turn off the oxygen. Now, a nasal cannula, which is a low flow device. This one goes into the nostril. It delivers low flow oxygen at 2 to 6 liters per minute in a concentration of approximately 35 to 50%, and the actual concentration is actually 24 to 28%, but we're not going to get too much in the percentages. Just understand that it can be adjusted from anywhere from 1 liters. So you can start off at 1 liter for nasal cannula, and it can go up to 6. And as a EMR, so even though the range is 1 to 6 liters per minute or 2 to 6 liters per minute, you will not exceed 3 to 4 liters in the field. If you have to go beyond 3 or 4 liters with a nasal cannula, your patient requires high flow oxygen. So might as well you give them the high flow. If a nasal cannula is going to be used for an extended period of time, then a humidifier is required, because if it's dry oxygen and it's going into the nostrils, it's going to burn. If you're going to use a nasal cannula for a lengthy period of time, then it needs to be humidified. For the non-rebreathing mask, it is used to deliver high flow oxygen, and the actual flow rate for the non-rebreather, so the approximate flow rate is 8 to 15 liters per minute. The actual flow rate is 10, 12, or 15. And most protocols now start at 12 liters per minute. If you're starting below 10 liters with a non-rebreather, the reservoir bag, which you can see in this diagram, so the reservoir bag at 8 liters per minute, this will not full properly and it might take longer to full up. So you want to start at 10, 12, or 15. And most protocols, it's going to be 12. Nothing is wrong with starting at 10, but most of the protocols now, it's 12 liters per minute. And there are now new regulators that can actually go beyond 15 liters. So there are now regulators that can go up to 25 and 50 liters per minute. And if you look at this particular, this is actually a partial rebreather, even though the slide is saying non-rebreather, because it only has one valve here, but yes, the other valve is there. I wasn't seeing it. Okay, so it has a flutter valve here and a flutter valve on this side and one in the inside. So when the patient exhales, the flutter valve opens up. When the patient inhales, it closes off, so the outside air cannot mix with the oxygen. It's pure oxygen. So yes, it is indeed a non-rebreather. Now with this particular device, the patient can get up to close to 90% oxygen concentration, which is more than enough for a patient that is having trouble breathing. That's more than enough. Now, continuing with a non-rebreather mask, remove the pointer, should be used for patients who require higher flows of oxygen, including those experiencing shortness of breath or difficulty breathing, severe chest pain, carbon monoxide poisoning, congestive heart failure, and signs and symptoms of shock. Now, hazards of supplemental oxygen. Supplemental oxygen must be used carefully so that your team and your patient remain safe. That is always your goal. So as EMS responders, our personal safety comes first. We do not put our safety at risk. So it's your safety, the safety of your crew members, and the patient and bystanders. You will need additional classwork and practical training before you are ready to administer oxygen in emergency situation. This I have already explained. So it's not a skill that I will be testing you on. It's a skill I will demonstrate so that you have an idea of what the equipment looks like and how the equipment is used, and you know the name of the equipment. But to be comfortable with the device requires more training or more classwork, and your assessment skills would need to be developed more, which is outside the scope of this particular course. Now, pulse oximetry is a device that you may have in your EMR toolkit. It is a device that measures the oxygen concentration in the blood within the capillaries. So it has a probe, and that probe is able to pick up the oxygen molecules that is on the red blood cell, and it gives a percentage. And the normal pulse oximetry should be above 95%. You will not see a person at 100% and they remain at 100% if they're breathing normal, because the other percent, the remaining percentage is necessary for CO2 and nitrogen. So we need CO2 and we need nitrogen in our body. Now, when you're going to use your pulse ox, do not treat the pulse ox. And this is a bad practice in EMS in Jamaica, something that I've observed. So we do not treat devices, we treat the patient. So the practice is to put on the pulse ox, look at what the pulse ox is saying. If the pulse ox is low, give oxygen. It doesn't work like that. So your pulse ox is a guiding tool. So you need to do an assessment on a patient. Then look at the pulse ox reading before you give oxygen. And then after you have given oxygen, look at the pulse ox reading again, and you'll be able to determine if your oxygen administration is working or it's not. So it's a guiding tool. So we do not treat the equipment, we treat the patient presentation. A patient can be hypoxic, and the term hypoxic means low oxygen. So hypoxia is low oxygen. So a patient can have hypoxemia, which is low oxygen levels in the blood, and their pulse ox reading is actually normal. That patient needs oxygen. We're not treating the pulse ox. And an example of that would be a patient with carbon monoxide poisoning. So a patient with carbon monoxide is going to have carbon monoxide instead of oxygen molecules on the red blood cells. The pulse ox is not able to differentiate the difference between carbon monoxide and oxygen molecules. So it's going to tell you that the patient has a good pulse ox when they're actually very hypoxic. So again, you assess your patient and you treat what is presented, you don't treat the device. The reverse to that is a patient can have a low pulse ox, and it doesn't matter how much oxygen you give the patient, the pulse ox don't change because they have a chronic issue, right? They've developed a chronic respiratory problem for many years, so their body is accustomed to low oxygen levels. So when you give them oxygen, the pulse ox still remain low because your body is not accustomed to that. It doesn't mean that the oxygen that you're not giving isn't working. It's just that the body is going to take a longer time to adjust to it because they have been living for so long without the high concentration of oxygen in the blood. So again, we do not treat numbers and we do not treat devices. You look at what is presented and you manage what is presented based on your assessment skills. So it's a guiding tool. The other thing that a pulse ox can do is it can give you a reading for the pulse. And this is what EMS responders love to do, especially the new generation, right? The new school or the new generation of responders. Put on the pulse ox, write down the number for the pulse ox reading, the percentage for the pulse ox reading, and then write down the pulse rate because it gives you a pulse rate and they didn't check the pulse rate, right? So they're just writing down numbers and treating numbers. So if your pulse ox gives you a pulse rate, you need to do a manual check to see that the physical pulse check matches the pulse reading on the pulse ox. And if you have a pulse ox, you can test this out. So put a pulse, if you have one available to you, put the pulse ox on someone's finger or your finger and check your pulse at the same time and see if your pulse matches what is on the pulse ox device. So that would be your pulse oximeter. So again, the normal percentage is 95 and above. It should be above 95. It can be at 95. Don't freak out. But it should be above 95%. That's considered normal. Now, in a healthy patient, the oxygen concentration should be between 95 and 100%. The pulse oximeter cannot tell you what is wrong with the patient, but it can help you. Again, the pulse oximeter cannot tell you what the issue is. Your assessment skills will be what determines that. So don't treat your pulse ox, treat the patient. So recognize that the patient is having a problem, determine whether your treatment is helping the patient. So if you're going to be giving oxygen, get that pulse ox reading on room air once the pulse ox is available. And then after you have given oxygen, look at the pulse ox. If it's going up, your oxygen treatment is working. If it's not moving or going down, then there might be another issue present. A pulse oximeter has certain limitations. It will not give you an accurate reading if the patient is wearing nail polish or has dirty fingers. If the patient is cold, won't give you an accurate reading either. If the patient has lost too much blood, reading might not be accurate. If the patient is experiencing carbon monoxide poisoning. There is no machine that can replace careful patient assessment. I don't need to say any more on that. Now, rescue breathing for patients with stomas. And a stoma is simply an opening in the patient's trachea. So that's a tracheostomy, an opening in the patient's neck. So for whatever reason, their upper airway was compromised and they needed a surgical airway, surgical opening to create an alternative route to the lungs. That's referred to as a stoma. Now, the most common issue with stomas is going to be mucus production. So these patients are not able to clear mucus production. Mr. Blake, we will not take any questions at this time. Stop hitting the hand signal. You're interrupting the lecture. Check every patient for the presence of a stoma. If you locate a stoma, keep the patient's neck straight, examine the stoma, and clean away any mucus in it. So mucus production is always going to be the most significant problem with these patients. If there is a breathing tube, remove it. Now, this is not a skill I will expect you to perform as an EMR. This is more for EMTs and higher. And we do not encourage using the mouth to ventilate the stoma. It's preferred to use a mask, a small mask, pediatric mask, or directly attach a device to the tracheostomy tube if one is present. But this is not a skill that I will emphasize at your level. The patient is going to need suctioning, and it has to be a flexible catheter that is used, and it must be a sterile technique. So for an EMR to perform this particular skill, additional classwork is necessary, and additional workshops will be required, because you need to be very comfortable with your suction device. You need to be very comfortable with your BVM device, because these are the two devices that you would be using. Now, gastric distension. This can be a major issue when giving rescue breathing in the field. And this is usually the result of ventilating a patient too forcefully or too fast, or the airway is not properly positioned. So it occurs when air is forced into the stomach instead of the lungs. So if the airway is not positioned properly and you squeeze the bag, if the air did not go into the patient's lungs, it went somewhere, and it's going to take the path of least resistance, which would be the esophagus, which goes to the stomach. Always assume that a patient who you find unresponsive has a full stomach. So be prepared to deal with a messy airway. If your airway management techniques are good, you should not have that issue. If the airway management techniques are poorly executed, then you will have that problem. And one of the most, I don't want to say difficult, but one of the calls that I will never forget as a EMS responder was my very first cardiac arrest patient. So this was my first cardiac arrest as an EMT. The call come in, it was the husband that called, and this was in Jamaica, called stating that his wife is not responding. He found her not responding. Took us a while to get there because it was difficult to find the location. I would say it took us probably 15 minutes or more. When we got there, the husband was attempting to do CPR, and was doing chest compression, and he was trying to breathe for her. There was no sequence to what he's doing. The airway wasn't positioned properly, and her stomach was severely distended, and vomitus started to come up in her ear passage. And if you're squeamish, don't listen to this part. The husband was actually trying to breathe for her through the vomit. So he was trying to breathe for her through the vomit. Based off what I saw at that point, I knew for sure there's nothing I could do to save this particular patient. Because if you have a patient like that, there's no way I can manage that patient's airway or do CPR until the airway is cleared. So if you have a patient with distension, that patient needs to be turned on their side, and you need to create pressure on the abdomen. As the vomiters start to come up, you clear it. And for this particular patient, it was thick vomiters, so it was also difficult to suction. Unfortunately, she did not make it. If the husband had proper BLS training, would it make a difference? She would have definitely had a better chance, but he was doing his absolute best, and it's unfortunate. So that was definitely a call I'll never forget. So it's very important that your airway technique is immaculate. This is a life-saving skill. This is a skill that you need to have constant workshops on. The day it occurs, you need to be ready. Now, dental appliances. If a patient has in dental appliances, what you need to note is if it is loose, it has to come out. If it's loose, must come out. If it's not loose and you can manage the airway effectively, then it remains in. That's it. So do not remove dental appliances that are firmly attached. They may help keep the patient's mouth full so you can make a better seal. For loose dental appliances, these can cause obstruction, so you want to remove these devices. Now, airway management in a vehicle. Use the jaw thrust maneuver, and this is not something I would expect for you all, because I think most of the persons in this course are from the industrial setting, so I'm not 100% sure if you respond to machine accidents or motor vehicle accidents, but this is more for firefighters or persons who are going to be involved in an extrication process. So if the patient is in a vehicle, use a jaw thrust maneuver if the patient is lying on the floor or seat, depending on how much room you have to work. If there is any possibility that the crash could have caused a head or spinal injury. When the patient is sitting or semi-reclined, approach a patient from the side by leaning through the window or across the seat. Grasp the patient's head with both hands, and when you're approaching a patient in an MVA or motor vehicle accident, you always try to approach a patient in the line of sight. And you communicate with the patient while controlling the patient's head. Sir, if you can hear me, don't move your head. Sir, I'm here to assist. My name is so-and-so. I don't want you to move your head. I'm gonna need you to keep your head still for me. Right? And you need to maintain a neutral position of that patient's head. And the person who is performing this task will be a part of the extrication team. So if you're not trained to do extrication, you should not be attempting this maneuver. Okay? And that is basically what it looks like. And always try and open the doors before cutting them off. And this is for the firefighters, right? Firefighters love to cut up people's cars, even though it don't matter at that point. But try to open the door before cutting it off. Try before you pry. Now, this particular technique has several advantages. You do not have to enter the automobile. You can easily monitor the patient's carotid pulse and breathing patterns by using your fingers. This technique stabilizes the patient's cervical spine and it opens the patient's airway. Again, if you are not a part of the extrication team, do not attempt this maneuver. So you need training to be able to extricate a patient, a serious trauma patient, properly. All right, and that would bring us to the end of airway. In summary, the main purpose of the respiratory system is to provide oxygen and to remove carbon dioxide from the red blood cells as they pass through the lungs. When a patient experiences possible respiratory arrest, check for responsiveness, open the blocked airway using the head tilt chin lift, which is for your medical patient, or you will use a jaw thrust maneuver, which is for your trauma patient. Once you have positioned the airway, check if the airway is clear. So check for fluids, solids, or dentures in the mouth and correct the airway if needed. You can use your finger sweeps or suction if you have a suction device available and it is indicated. Maintain the airway by continuing to manually hold the airway open by placing the patient in the recovery position or by inserting an oral or nasal airway. And remember, for these particular adjuncts, you must look for your indications. If the airway is obstructed in a conscious adult or child, kneel or stand behind the patient and perform abdominal thrust or Heimlich maneuver. It's no longer referred to as a Heimlich maneuver. Now, administering supplemental oxygen to patients showing signs of and symptoms of shock increases the amount of oxygen delivered to the cells. Now, signs are the things that you can see, hear, smell, and what can be measured. So that's your signs. Symptoms is what the patient complains of. Pulse oximetry is used to assess the amount of oxygen saturated in the red blood cells. And that would be the end of this particular chapter. Question 1. After opening the airway of a patient who has a pulse but is unconscious, you should do what next? You can type in the chat.